Welcome to Grand Rounds again today. Today we have a lecture by Samira Hussain, one of our residents, who's going to be educating us on some of the newer and finer points of adolescence and contraception. Thank you very much.
Thank you. Okay, so the title of my talk. Yes. Yes. So the title of my talk is Helping Adolescents Choose Prescription Contraception. I'm one of the third-year residents. Again, my name is Samira Hussain, and Dr. Lance helped me with this, so thank you so much for your help. So the goals of my presentation are to review trends in teenage pregnancy and contraception use, review the various forms of prescription contraception, review contraindications for the different forms of contraception, and to discuss how to help adolescents choose contraception and use it effectively. So I have no disclosures, and although several name brand medications will be discussed in this presentation, I have no financial relationship to any brand. So the reason, this is sort of the reason I decided to talk about this topic, is because pediatricians do have a role in managing contraception. Sexual health is an important part of adolescent anticipatory guidance and screening, and primary care providers should be doing this. Pediatricians also have a long-term relationship with patients and families. This can be helpful in promoting healthy sexual decision-making. And also, as primary care providers, we can use prescription contraception to manage other medical concerns such as dysmenorrhea or heavy menstrual bleeding. So first we'll talk about adolescent sexual behavior. In 2011, 47% of high school students reported ever having sex, and 34% reported having sex in the last 3 months. Each year, over 500,000 adolescent girls become pregnant, and most of these result in birth, and the rest result in miscarriage or abortion. And here is data in the last several years, starting from early 1990s to 2015, and this is teen birth rates. And as we can see, for adolescents between the ages of 15 and 19, this is trending down. And some of this can be attributed to consistent contraceptive use. So that's a good thing. And then here is our local data. So this is teen pregnancy rates per 1,000 females by age. So here we have the pregnancy rates in Virginia as a whole for the years of 2013 to 2015, and so we can see that it's trending down. However, if we look in Roanoke City, we can see that the pregnancy rates are pretty high for teenagers, especially as they get older, between the 15 to 19 age ranges. And as a county, there's a little bit better of pregnancy rate, but still pretty significant. So first, I thought I'd talk about the most commonly used methods among adolescents. So on the left, we have lifetime use, meaning adolescents who have ever used contraception, and this is data from girls between the ages of 15 and 19 between the years of 2006 and 2010. And almost everybody reports using some form of birth control at some point. Most of them are using condoms, and of the prescription ones, pills are the most commonly used ones. And we'll talk about why that's significant in terms of efficacy. And then here on the right, we have current contraceptive use by women between the ages of 15 and 19 between 2006 and 2008. Although here, most people are saying that they're not using contraception and they're not currently sexually active, of those using contraception, pills are most common. Pills are the ones that are most commonly used, and only 28% say that they're actually using contraception. So this leads us to the different forms of contraception and which ones are the most effective. So here we have percent of women getting pregnant after using a particular form of contraception for a year. And they divide it into typical use and perfect use. And so typical use means that the probability of getting pregnant with normal use. And this comes from national survey data that includes varying degrees of adherence. And then perfect use, which is here, is the probability of getting pregnant if used consistently and correctly every single time. And this comes from clinical trials with very high levels of adherence. And so with no contraception, there's 85% of women get pregnant. And then, and this with various forms of barrier contraception, there's about, the typical use is like 20% of women will get pregnant. However, when it comes to the prescription contraceptions, you can see that they're much less likely to get pregnant. And so these are much more effective. So for this talk, I thought it would be helpful to review what we learned back in medical school. So this is the menstrual cycle, as we all remember, some of us started learning about. So it starts off at the beginning of the cycle, FSH and LH begin to rise at the start of the cycle, and this is when estrogen is really low. And at this point, we have multiple follicles that begin to enlarge and secrete estrogen. So this results in our gradual rise in estrogen, and one follicle becomes dominant and secretes a large amount of estrogen. So you have this marked rise of estrogen. So this causes a positive feedback on gonadotropin secretion and results in LH surge. This is when a follicle will rupture and the corpus luteum secretes a large amount of estrogen and progesterone, mostly progesterone. And as the corpus luteum degenerates, you get a drop-off of the progesterone and estrogen levels. And that's when menstruation occurs, when estrogen and progesterone levels drop off. And it's mostly the progesterone that results in, causes that fluffing of the endometrial lining. And then so if we go back here, during the proliferative phase, estrogen causes endometrial thickening. And during the secretory phase, you get continued thickening of the endometrial lining, and a lot of blood supply and glands form to secrete different hormones. And this helps create that hospitable environment for an embryo. So in terms of prescription contraception, I was going to start off by talking about the long-acting reversible contraceptives, and these are the intrauterine devices and subdermal implants. So these are the most effective reversible contraceptives available for women, including adolescents. And it's recommended that pediatricians use a tiered approach to contraceptive counseling, starting with the most effective methods. So here they are. We'll start off with the subdermal implant. So these are two of them. Actually, this one called Nexplanon has replaced Implanon, and there was an older one called Norplant that's not even on the market anymore. And so the subdermal implant is a 4-centimeter rod that's placed under the skin, and it releases 60 micrograms per day of the progestin called etonorgestrel. And what this does is it suppresses, so the subdermal implant has, the progestin level is high enough to inhibit the LH surge, which suppresses ovulation. It also causes thickening of the cervical mucus, which creates a barrier for sperm transport, and it also leads to an atrophic endometrium. So as I mentioned, both of those that were shown before are equivalent. It's just that the Nexplanon is radio-opaque, and it has a slightly different applicator. It's radio-opaque, so it can be seen on imaging, which can be helpful if the patient forgets that they have it or it's difficult to find when taking out. So how is it placed? It's placed during an office visit with local anesthetic, and it lasts for 3 years. And after that time period, a new one can be replaced, can replace it. And so taking it out involves a small incision, and you get fertility back pretty quickly after removal. So the contraindications for this is obviously pregnancy, progestin-sensitive cancers, liver disease, allergy to product components, and efficacy may be impaired by hepatic-inducing drugs. And we'll talk a little bit more about that later. Some adverse effects are irregular bleeding. So this is the most common reason why women decide to stop using it. And headaches, acne, and weight gain are far less common but have been reported. There is pain, there can be pain, infection, or bleeding after insertion, and their removal might be difficult if there's any scar tissue or if it was inserted very deeply. And then also, women who are more than 130% of their ideal body weight or have liver enzyme-inducing medications may have reduced efficacy of this form. So next we have IUDs. These are intrauterine devices, and here are the three that are on the market now. So IUDs are actually, I was surprised to find out that they are the most widely used contraceptive worldwide, and but they're not used very much in the U.S. because there's a lot of myths regarding its safety. And so current IUDs do not cause pelvic inflammatory disease. The absolute risk of infection is less than 1%, and it exists within the first 3 weeks of insertion. And return to fertility is pretty rapid after removal. And the American College of Obstetrics and Gynecology actually recommends IUDs as a first-line contraception for all women, regardless of age or parity. So here are the different types of IUDs. So the first one is called Paragard. So this one contains no hormone. It does contain copper, and copper is thought to add to the foreign body reaction of the IUD itself. And IUDs work primarily by creating an inflammatory response in the endometrium, and then you get that influx of macrophages, prostaglandins, cytotoxic peptides. So the copper is also thought to impair sperm function. So with this form, patients it does not affect ovulation. So patients will still ovulate, and they will still get their period. But what's nice about this is that it's effective for 10 years. So the Mirena is a hormone IUD. This releases 20 micrograms per day of levonorgestrel, and it causes, so this progestin release from the IUD causes thickening of the cervical mucus, which prevents sperm penetration, as I mentioned before, and it causes a reversible endometrial atrophy. Follicular development and ovulation are partially inhibited in some women after the first year of use. And so this is effective for up to 5 years, and it's specifically approved for women who get heavy periods. The next one is called Skyla. This is newer than Mirena. It releases a little bit less of the levonorgestrel at 14 micrograms per day. It has the same mechanism of action as Mirena, but it's effective for only 3 years. There's 2 more that are coming out. One of them has a smaller insertion device than the Skyla, and there's another one that will be effective for 5 to 7 years. But those are not available quite yet. So the benefits of IUDs. So there's improvement in dysmenorrhea and heavy menses. So levonorgestrel IUDs decrease blood loss during menses by about 90%, and they induce amenorrhea in about 20% of users, which is considered a positive thing. And we can see how this would be advantageous in preventing iron deficiency anemia, and it can be used in patients with estrogen contraindications. So these can be placed in the office. A bimanual exam is done to determine the size and position of the uterus. It requires a speculum exam as well. So insertion is done with a sterile rod called a sound through the cervix to determine the depth of the uterine cavity, and then you have sterile insertion of the IUD through the cervix. Placement is usually verified at the bedside with a transabdominal ultrasound, and what's nice about this is that it can be removed at any time, and things like tampons and stuff are not a contraindication. So here are the contraindications: pregnancy, pelvic inflammatory disease, any postpartum or post-abortion sepsis within the last 3 months, a current STI or purulent cervicitis, undiagnosed abnormal vaginal bleeding, malignant tumor of the genital tract, abnormalities of the uterine cavity that prevent insertion, things like bicoordinate uterus or something like that, allergies to any components, and Wilson's disease is a contraindication for the Paragard. So here are the adverse effects of it. It can increase menstrual bleeding, including spotting and menstrual pain, but that's just mostly for the copper-containing IUD. But the hormone-containing IUD often decreases menstrual bleeding and dysmenorrhea, so it actually works out pretty well, and some experience amenorrhea. So those were the different forms of the long-acting reversible contraceptives. Now we'll move on to forms that are not considered LARC forms of contraceptives. And the first one we'll talk about is the progestin-only injectable contraceptive. So this is injectable medroxyprogesterone, and it can be given as a 150 milligram dose IM or 104 milligrams subcutaneously. And this is the second most commonly used hormonal contraceptive in the U.S. So this one lasts for 3 months, and so in this one, circulating levels of progestin are high enough to prevent that LH surge. So this suppresses ovulation, thickens cervical mucus, and induces an atrophic endometrium. And it may take up to 9 months to return to ovulation after starting it. This can be a good choice for teens who have a contraindication to estrogen or who are on enzyme-inducing medications such as anti-epileptics or antiretrovirals. They can be started mid-cycle even if pregnancy can't be ruled out. So the adverse effects of this would be menstrual irregularity, however, most will experience amenorrhea. And this menstrual irregularity, from what I've seen, it's more at the beginning when you start it and eventually it gets better. Weight gain is also considered an adverse effect, and on average, there's a 5-pound weight gain in the first year after use, and then 8-pound weight gain in the first 2 years. However, not clear if it's actually due to this medication. And then also bone mineral density. There's thought to be a decrease in bone mineral density. However, it depends on the studies that you look at regarding this. But what was found is once patients stopped using this, the progestin injectable, bone mineral density returned to normal. So it's sort of a reversible effect, and there's no data that actually links this to increased risk of fractures. So now we'll move on to the different forms of combined hormonal contraceptives, and these contain both estrogen and progestin, and here are the different forms. We're most familiar with pills, but also there are patches and rings. We'll go through these as well. So as I mentioned, they all contain a combination of progestin and estrogen. So what these do are progestin causes that LH surge, which inhibits ovulation. So this causes thickening of cervical mucus to feed sperm, and it also inhibits peristalsis of the fallopian tube, which is thought to prevent transport of sperm and ova. And then there is estrogen, which suppresses the FSH secretion and suppresses follicular development. This increases intracellular progestin receptors and potentiates the action of progestin. And so this potentiating action of estrogen on progestin allows for lower doses of progestin in the combined hormonal contraceptive. So here are some of the adverse effects of combined hormonal contraceptives. One myth is that it can cause weight gain, but it does not cause weight gain. Metabolism of other medications such as anticonvulsants may be affected by the estrogen component, but the main serious risk is venous thromboembolism. And so for this, it's important to counsel patients about this serious concern. So they should all be counseled on the symptoms of it, and this is a mnemonic that you can use to kind of help them and to help yourself remember signs of VTE. And it's ACHES, which stands for abdominal pain, chest pain, headaches, eye problems, and severe leg pain. So contraindications are obviously teens who have a history of VTE, those that with known thrombogenic mutations, those with migraine headaches with focal aura, uncontrolled hypertension, hepatocellular disease, breast or liver cancer. Smoking is discouraged, but it's not really a contraindication. So there are also benefits of combined hormonal contraceptives. One is the improvement in dysmenorrhea. There's a reduction in blood loss. And because you have reduced circulating androgens, there's improvement in acne and hirsutism. There's a reduced risk of endometrial and ovarian cancers with use for many, if you use it consistently for many years, and a reduced risk of benign breast conditions. And it can also have favorable effects on lipid profiles, such as lowering of, increasing of HDL and lowering of LDL. So this oral contraceptives are the most commonly used hormonal contraceptive among teens, and they can be started on the same day of the visit or the day after using emergency contraceptive. However, backup methods should be used for the first 7 days after starting. So with these, patients need to be counseled on the fact that it's daily dosing, which can be difficult for teenagers and a lot of people to remember. So encouraging to add it to another daily routine is good, like brushing their teeth or set cell phone alarms or use apps. And there are plenty of apps available for period tracking and birth control tracking. This one here is called Spot On. This is put out by Planned Parenthood. And this is another one called Clue, and it has talks about levels of fertility throughout a patient's cycle. And for the one that's called Spot On, if you put in all your information, it'll ask you if you took your pill today, you would say yes, but it can help you troubleshoot if you have some questions. If you didn't log your pill, it'll say you didn't log yesterday's pill. If you missed it, be sure to take both yesterday and today's pill, which is what you should do, and we'll talk about that. So with all the options there are for oral contraceptives, most teens will start with a monophasic pill with 30 to 35 micrograms of estrogen and a second-generation progestin such as levonorgestrel. So where do you start with prescribing these? So it's important as providers for us to be familiar with a couple of these pills to start off with. And if patients have some adverse effects, if they're not serious, if it's like spotting or irregular periods, and they can bear with it for the first 3 months, try to encourage them to do that. Otherwise, you can have them switch to a different pill or a different form of contraceptive based on what issues they were having. So when choosing oral contraceptives, there are some that are contain drospirenone, and this is a newer class of progestins. They have, they're marketed as having lower androgenic profiles, so this can help with acne, bloating, and hirsutism. So it's important to think about the dose of estrogen when you're prescribing oral contraceptives. Most of them contain 30 to 35 micrograms of ethinyl estradiol, and this is actually considered low dose. But then you have these ones that contain between 10 to 20 micrograms, and this is the ultra low dose. So the use of the very low or ultra low dose has been shown to be associated with reduction in physiological acquisition of bone mineral density compared to the non-users or users of the 30 microgram pill. And then, so the ultra-low dose pills are also associated with menstrual irregularities. So these might not be a good choice for adolescents, the ultra-low dose. There is a 50 microgram estrogen pill, which is considered high dose, and we just don't use those in teens because that's too high for them. Next is to consider cycling of the active drug. So you can have monophasic, biphasic, and triphasic, and this simply refers to the dosage of progesterone and how it changes. Typically for teens, we use monophasics because they're just a lot easier to use. And so in combined oral contraceptives, there are changes in the numbers of active and hormone-free pills. So the traditional oral contraceptive pill pack contain 21 active pills and 7 hormone-free ones. And then you have newer options that contain 24 active and 4 inactive ones. Over those inactive ones, some of them contain two pills with lower estrogen dosage and some 2 that contain no hormones. That would be like, create like a weaning effect of that estrogen. Another option are extended cycles, in which there are 84 active and 7 hormone-free pills. And so if you use these, then you would get 4 periods per year. And this is kind of an example of what that pill pack would look like. And so if a patient cannot get specifically packaged extended cycles, then what you could do is you can use any other OCP, and in the same way, you would just eliminate the hormone-free pills for 3 cycles, and then take them at the end of the 4th cycle. However, if you don't even need to use any of the hormone-free pills, you could just continue taking the hormone pills if the patient desired to. So next, with teens, it's important to be able to counsel about what to do if you miss a pill. So this is what you would do if you miss 1 pill. If 1 hormone pill is late, or if 1 hormone pill has been missed, like it's been 24 to 48 hours since the pill should have been taken, they would simply take the late pill or missed pill as soon as possible and continue taking the remaining pills at the usual time. No additional contraceptive is needed, and no emergency contraceptives are needed. So what to do if you miss 2 or more consecutive pills? You would take the most recent pill as soon as possible and discard other missed pills, and then continue taking the remaining pills at the usual time, even if it means taking 2 pills at the same time, taking 2 pills on the same day. You would counsel them to use backup contraception or avoid sex until hormone pills have been taken for 7 consecutive days. However, if pills were missed on days 15 through 21 of a 28-day pill pack, they would just not take their hormone-free pills and start a whole new pack. And you would counsel them to use backup contraception until the new pack has been taken for 7 days. So we talked a little bit about medications that can affect or decrease efficacy of combined oral contraceptives, and here are a list of some of them. It's, at the top it shows rifampin as an antibiotic, but I would recommend that if they're taking any antibiotic that they should be aware that it could impact efficacy of their birth control, and they should probably use something else as a backup. And then also subdermal implants can be affected by many of these drugs as well. So it's important to, and as primary care providers, we would be more familiar with their other medications are. So it's good to be mindful. And then in terms of combined hormonal contraceptives, besides oral pills, there is the transdermal patch. And so this contains 20 micrograms of ethinyl estradiol and 15 micrograms of the progestin noreldestromine. So the patch is changed weekly for 3 weeks, followed by 1 week of a patch-free interval, and it can be placed on different parts of the body, and here they recommend either the hip, the buttock, the shoulder, or the arm. So some of the adverse effects of this is that it results in prolonged steady state of estrogen in the body, and it has similar effects as the pill. Additionally, it can cause worse nausea and some skin irritation, and there may be an increased risk of VTEs, and this is due to a much more efficient delivery of estrogen. The other combined hormonal contraceptive is the ring. This is a flexible latex-free ring containing ethyl estradiol and the progestin etonorgestrel. And for these, these can be placed intravaginally for 3 weeks and removed for 1 week, or can be kept in for 1 month and replaced on the same day every month. And keep in mind it contains enough medication for 35 days, but it would probably be easiest to just counsel them to change it on the same day every month. So these can be started on the same day as the office visit and can be used continuously with no planned ring-free days. However, they may cause some vaginal irritation or discharge. Rarely would they fall out, but if for some reason it did, they just rinse it and reinsert it. If it's kept out for 3 hours, then they'll need a backup form of contraception to use for the following week. And so with this form, there would have to be a certain comfort level with inserting it and removing it. To insert it, if they prefer, they can use a tampon applicator, but there would have to be manual removal with a finger. Also, for this form, it's important to keep in mind that after it's picked up from the pharmacy or whatever, it needs to be kept in a cool place because body heat actually activates it. So if it's kept in a warm car or something, it would probably be less effective. So something to know about starting combined hormonal contraception in general. It does not require a pelvic exam. In fact, none of them require a pelvic exam except for IUDs, which are actually placing the device into the uterus. You should perform chlamydia screening on all sexually active women younger than 25 years of age, regardless of their number of sexual partners. And pills can be started at any point in the menstrual cycle. However, they're not as effective as if started outside of the first 5 days of the cycle, and they should use another form of contraceptive for 7 days after starting. Next, we have progestin-only pills. These are useful for teens who are interested in an oral form of contraception but can't take estrogen. These act by suppressing ovulation and thickening cervical mucus. However, they have to be taken daily with no pill-free intervals and must be taken at the same time every day, and you can't miss a pill. Otherwise, you'll get breakthrough bleeding, and there can be method failures. And these are much less effective than the progestin-only IUDs, implants, and injections. So probably might not be as good of an idea for adolescents. So next we come to the emergency contraceptives. These are the ones containing levonorgestrel. So you can get a 1-pill medication that contains 1.5 milligrams of levonorgestrel, or you can get the 2 75-milligram tabs, which are meant to be taken 12 hours apart, but they can also be taken together. They should be taken within 72 hours of unprotected sex. However, they can be taken they're still effective up to 120 hours after sex. So these prevent follicular rupture and ovulation. They have little or no effect after the LH surge begins. And studies where patients took this emergency contraception on the day before or day after ovulation, the expected pregnancy rates in these patients were seen. So some more things to know about this. The adverse effects include nausea and abdominal pain, although this is rare. Pregnancy is a contraindication, however, it will not disrupt an established pregnancy and does not have adverse effects on the fetus. And a pregnancy test is not required for prescribing it. This is available over the counter without an age restriction. However, patients are more likely to use it if a provider prescribes it to them before they need to use it, so they have it on hand when they need it. And this is another form of emergency contraception. It's called ulipristal acetate. It's a progestin receptor agonist and antagonist, and it can be taken up to 120 hours after unprotected sex. It's only available with a prescription, and pregnancy tests should be done prior to use. So this is a pregnancy category X, so it can cause harm to a fetus. It can also cause ectopic pregnancy, and if it causes nausea and there's vomiting within 3 hours, it should be taken again. So this form delays or inhibits follicular rupture when given before the onset of the LH surge and is effective prior to the LH peak. So, and what's important to keep in mind is that this medication binds to progesterone receptors and can interfere with progestin-only pills, subdermal implants, and OCTs. So if they take this, they should use backup barrier contraception until their next period. Okay, so those are all the forms of contraception, prescription contraception I wanted to talk about. And so these are kind of, after learning about all of those, these are some of the things to think about as you counsel adolescents about their options. So it's recommended to start with the most effective methods, and those would be abstinence, which is definitely an option, or the LARC forms, which are the IUDs and the subdermal implants. You need to think about if they have medical contraindications. Can they have estrogen or not? What are their plans about how quickly they might want to return to fertility once they stop? And you should also think about their willingness to receive an injection or an insertion of something into their bodies. Are they squeamish about getting shots? And the injectable form wouldn't be for them. Can they take a pill? Are they willing to swallow a pill, and can they take it reliably every day? And also confidentiality status. Do they need a form where, people that they live with aren't supposed to know that they're on a contraception? So maybe something that they don't have to have around, like a pill, might be better. So an injection, IUD, something like that might be better for them. And need to consider their ability to return to a clinic or a pharmacy. And this can be an issue for adolescents taking either a pill or even an injection, because they need to come back and get that injection. And regardless of all these forms of contraception, they always must use a barrier method to prevent STI, because none of these prevent STI. Are there any questions? Oh.
I may be showing my age. Is there a black box warning still on depot for bone mineral density?
There is. There is a black box warning, but as I mentioned, studies have shown that the lower bone mineral density is reversed once they stop taking it, and there's no risk of fractures on it, like an increased risk of fractures with depot.
Samira, at the very beginning of your talk, you showed the statistics for Roanoke City and Roanoke County, and I was struck by the rates of pregnancy for the 18 to 19. It's like 1 in 10, basically. So that strikes me as it's not that they are trying not to get pregnant that they probably are trying to get pregnant. Is that a reasonable thought? And if it is, how can we? That's a cultural issue, and how can we affect that?
That's a big question. Well, I didn't. I would need to know why they want to get pregnant. Do you happen to know of any reasons of why? Because I haven't come across seem to have actually directly told me that they want to get pregnant.
Kind of a culture.
Hang on.
Sorry. There is unfortunately a bit of a cultural component to that in our community, and so it scares us every day in the teen clinic how many gals come in for a pregnancy test that have checked off that they're trying to get pregnant, when perhaps the timing in their life, as some of us over 18 and 19 know, may not necessarily be so ideal for them. And I think the way we affect change in that is just education, and starting to talk about this topic earlier rather than later, is probably the biggest key thing we can do as pediatricians.
Also, I think for me personally, I would want to know why they want to get pregnant. I would need to understand that better and kind of help them understand what life would be like once they got pregnant and for the rest of their life after that. So I guess that would be my less experienced approach to it. I don't know if that would be how that would work out.
Good. Thanks for your talk, Samira. Mm-hmm. I may have missed it. What's the reason to do birth control pills with very low dose estrogen? And a separate question, what about drinking grapefruit juice and birth control efficacy?
So the reason for the ultra low dose, the 10 to 20 microgram pills, it's just for people who are like, oh, I don't want to take very much hormone, but it's not as effective. And so the 30 to 35 microgram pill, which is pretty much like, I would say more standard now, is actually considered low dose. I would not prescribe an ultra low dose because it causes bleeding, irregular periods, and it might be less effective in teens. I would just stick with 30 to 35 micrograms. As far as the cranberry juice, or grapefruit juice, I'm not too sure about that. What have you heard regarding it?
It's another hepatic inducer. Does it make the birth control more effective or less effective? Okay. I don't think there's any data. Okay.
No,
so you don't worry about that. Our kids don't drink grapefruit. Yeah, our kids don't drink grapefruit juice. There's a potential for a fad diet.
Hey, Samira, I want to go back to the comment that Don made about teenagers wanting to get pregnant. Amy and I, who work in Daleville, were having a side conversation while that was going on. Even in our suburban practice, we see older teens wanting to get pregnant all the time. And the reasons that we can see are kind of multifactorial, but they're social in a lot of cases. That, for example, one of my girls last year was trying to get pregnant to avoid going to a long-term residential center. Yeah, I know. So it comes from all sorts of life events that they have. But it's one of those social determinants of health that we all need to look at, and we all need to think about doing a better job and how we can affect these decisions before it gets to that critical of a point.
All right, I'll come up to you in just a second.
Well, I got to ask two questions. Is there any psychosocial research that looks at these birth control tracking apps, these things on people's smartphones, whether that actually increases compliance? Because I would think somebody would have thought to do that study.
Yes, there are studies that look at the different apps, and they go through, the various factors that what about the apps makes them better and makes people use their birth control more, but I didn't really delve too deep into that. But there are studies about that, so that would be interesting to look at.
So I started seeing women who were put on an IUD come back with complaints of acne and ovarian cysts were no longer under control. And the option was to start an oral birth control on top of their IUD, as this idea that you're getting the anti-pregnancy from your IUD and potentially the hormonal effects from the birth control. Is there, I mean, what are your thoughts on that, and is that recommended?
For that, and then they weren't interested in removing it probably because they wanted to have that long-term. I personally haven't. Is this more in older women or teens?
No, I guess it's more older women.
Okay. I didn't read too much about that occurring as much in younger women. Is that something that you guys see often?
I think what you're referring to is the estrogen add back. And so as long as there's not an estrogen contraindication, you can give, and the progestin difference when you add an oral contraception on top of either already getting depo or having a implanted SUBDERMAL or IUD that just has progestin in it is minuscule. So there's really not a problem with adding extra progestin, but you can add, this might be a case where the low dose or ultra low dose birth control pills might be used to give folks back a little bit of estrogen on top of those IUDs. And so sometimes that'll mitigate some of those progestin-only side effects by giving folks back a little estrogen. So that's why that's done.
When you were talking about talking to adolescents about the types and could they get to a pharmacy if that's what they chose, and could you comment more on the confidentiality and the age, and if an adolescent comes to you and says, I don't want my parents to know, but I need contraception, can you prescribe that kind of thing, age limits, anything that you can comment?
For things like emergency contraception, you can, I think throughout the country, you can obtain that from a pharmacy without any problems. Well, actually there are problems. Some pharmacies don't give it as readily. So it's good to give them a prescription for that ahead of time and get that filled. As far as confidentiality goes, you know, you would still encourage them to talk to their parents about it. You wouldn't, you know, would try to get them to talk to their parents about it, but you would still go ahead and prescribe it to them, regardless of whether they've had that conversation with their parents.
We have it at our clinic. We have it at our clinic.
Oh, it's available at the adolescent clinic. You don't have to talk to parents at all then if that comes to that.
Maybe that's the answer, and of course I have a 15-year-old now, so now I'm really worried. But but in terms of, I mean, the age-old, you know, the parents pay the bills. I mean, how do you keep that confidential, especially if you're writing a prescription?
So you could go to clinics where you can actually access it as our teen clinic actually has some. So that's an option for them. If they absolutely can't let their parents know, that I would suggest that would be the best, safest way to do it.
I can explain that a little bit better for you. So, because we deal with this a lot. They can get certain pills and depo from our clinic at very low prices that most of them can afford with cash payment without parent notification. Most pharmacies like Walmart, Kroger have the discounted birth control for about $9 a month. So they can get it there, and the key is you go in, you tell them you don't have any insurance, you're a cash paying patient, and then it's not billed through their insurance. And the trick to that, though, that we found is that if they've had prescriptions filled there before, the pharmacy has an automated thing that will call their house and say, your prescription's ready. They won't say what it is, but your prescription's ready. So I also tell my patients, if you really don't want mom and dad to know, you need to give them a different phone number to call.
Yep.
I know all the tricks.
Longer cord.
So kind of in the beginning, Samira, you were talking about those longer-acting reversible contraceptives that are currently first line. That's where we're supposed to start. We're not being trained as pediatric residents to put in an implant on or to place an IUD. And I know when I was at the adolescent clinic, I mean, those are getting referred. So if you're talking to an adolescent about needing to have something like an implant on or an explant on or an IUD placed, you're talking about having to be able to get them to an OB appointment or a GYN appointment to get them a consult and then to go back and have to have something placed. So I think, in my opinion, I think a lot of times that's where you get a lot of pushback from an adolescent who says, yeah, I think that'd be a great idea, that I wouldn't have to worry about it for the next 5 years, but I think you come into a lot of barriers there when it comes to those, because we're not being trained to do those things. I don't think that that's
I agree, and that's something that, you know, there's nothing to say that we as pediatric residents can't be trained to put these in patients. We're just not being trained to do that here. So I think that also these companies provide training sessions for pediatricians to learn, or for anybody to learn how to place them. So that would be something that might help pediatricians kind of provide this for their patients. And if we're saying that as pediatricians we have this long-term relationship with our patients, which is very important in kind of like, you know, having them feel comfortable with them talking to us about, you know, their sexual health, we should probably be willing to provide what we're recommending. So I think that more pediatric residents should be trained or have a way to get trained in placing those.
I did just get a survey recently of program directors about residency training on long-acting contraceptives. So I think that there is a realization that this is something that is needed. You know, I think we in the initial starting of this residency program, I think there was some interest in training all the residents to do that. And that's something I think we could definitely do here. I think we would just need to think about whether that's something that we want to do universally. And then if you're going to learn a procedural skill, if you don't use it, you will lose it. So trying to figure out what's the best way to do that and have people actually use it. You know, do we want to do it for everybody, and is that something you want to, like, how can we get you practice, or do you want to do it before, like, towards the end of your training? And I think there is some of the companies that make these medications may help fund some of this training. So certainly if there are pediatricians in practice that wanted to get trained, I think we could help you figure out how to do that. We have good local resources.
All right. Any other questions in the room? We have 5 minutes left, so I can unmute the phone. Lots of people online today. All right. I'm going to unmute the phones here in just a second. If you do not have a question or if you do not want to make a comment, just please put your phone on mute so we don't hear what's going on in your background.
The conference is now in talk mode.
Okay, the phone lines are open. Does anyone have a question for our presenter? Dr. Hart's not on the line, so.
I am too.
Oh, there he is.
I know. How does this affect abdominal pain? No, just kidding.
Thank you, Dr. Hart. You're always a good sport. Anyone else on the line or in the room have a question? No? Okay. Thank you very much. Okay. If you're still on the line and you wanted to ask a question, you can always email us at outreach@carilion.org, and I will get them to our presenter.
I know, right?
Go ahead and phone lines now. Thank you all very much for joining us.